country continuing to experience power cuts, the Limpopo Health Department is handing over generators to some of the province's hospitals. This to ensure these hospitals can function with minimal disruption during the blackouts. 11 generators have been handed over to selected hospitals. Health facilities have always had backup generators, but these have been meant for short-lived power disruptions and not the outages that we've been seeing lately of up to 4 hours. While government is working on exempting hospitals from the power cuts, how crucial is it for healthcare facilities to have functional alternative power sources? To discuss this further, we speak to Limpopo Health MEC, Dr. Phophi Ramathuba. Thank you very much, Doctor, for joining us this morning. An important initiative that your department has instituted in the province to make sure that hospitals and health facilities are functioning for the people during the blackouts. Tell us a little bit about the initiative and the selection process that was used to where the generators would be sent in different parts of the province.
Morning, Ramathuba, and morning to your viewers out there, and thank you for inviting us. Yes, indeed, what we did as a department, as part of mitigating and the plans that we made as last year, when we realized that the load shedding stages continue to increase, and we realized that we might be with load shedding for quite a longer period. We then began a process of auditing all our generators in our facilities, which you have rightfully so have always been there. But unfortunately, the capacity of those generators were not meant for the load shedding, for instance, your stage 6 or your stage 4. And these are the generators who would run in case for 30 minutes, in case when you, for whatever reason, probably municipality while fixing, then there's the challenge which will result into power a failure. But unfortunately, you would notice that during that period in the past, generators will be maintained probably once in 3 months, sometimes once in 6 months. Currently, we have to maintain them almost every month, sometimes every second month. And testing for generator, whether they're working, we are currently doing on a daily basis because load shedding is happening frequently. Now, after doing that audit, we realized that the lifespan of our generators is going to give us challenges. They won't be able to cope with the frequency of use. They are going to have to fail. So depending on the facilities, for instance, with the 11 that we have procured already delivered, we are talking about between 500 and 800 kVAs. And these are big generators that are able to run your tertiary facilities, even some of our regional hospitals, even though they will need even 2 or 3 to run one facility. Now, there are hospitals like CN Patudi, whose generators' lifespan has come to an end. It broke down, the technician went to fix, and they realized the parts that are needed are not even around in the market, and you can't even fix it. Hence, we have already installed one of these 11 ones. The pharmaceutical depot also we've already installed. Mukopani, while we were able to fix its generator after it broke down some 2 months ago, we are not comfortable that this generator will be able to pull through. Hence, we are also prioritizing them. You'll remember sometimes last year, there was the generator in Philadelphia broke down, and it took us more than 2 months to procure a new one. We had to even go and loan, and to loan one, to find one, they are not even there in the market. It took us more than a week, and we were struggling. So we said, learning from the experience that happened sometimes last year in Philadelphia, let's make sure all our generators are audited. We know now their lifespan. So the process is in terms of distributing. Every hospital has got a technician who on a daily basis, before they even go to work, they must check the status of the generator. The CEO is also given the responsibility to give us the report, updating us on the status of the generator. So if it broke down, while you are waiting for the technician to come to fix or waiting for the parts to be bought to fix it, we then will loan you, because there will be generators that are mobile, stationed in head office, that will be rotating to go and make intervention wherever there is in case of emergency.
Doc, this is obviously not a cheap exercise. We do know about the cost of diesel and the pressures that exist there. Are you confident that you are able to sustain this solution for the medium term, at least, when it comes to the cost of operating generators at these health facilities?
Of course, while it's putting up a huge strain on our budgets that we have, the reality of the matter is that a hospital cannot even go for a minute without a power supply. And hence, we have to make some means and reprioritize. The reality is we have never run short of diesel in all our facility, even though we did not really put the budget for the diesel, but making savings somewhere, realizing that there are areas where indeed you can do without. I mean, I must appreciate the team in the Department of Health. We have come to used to, for instance, eating in our meetings or functions. It has become a luxury for us in the Department of Health. So basically, our teams does understand that you can have events, you can reduce such costs. They might appear to be not really much, but some of those are the areas where you cut costs, where you can live without, because you know you can't live without a generator. So that is how we are able to make provision for the funds towards procuring a diesel. And also in terms of getting a contract that would be supplying diesel, because what we have realized, leaving it for the institution, for them to be able to get 3 quotations to get their own suppliers of diesels, there have been a lot of manipulation of the system. No, even our service providers, they are not honest. The prices were fixed, or prices were even escalated. When you look at the market price, you realize here we are being taken for a ride. So that process has been able to make us realize quite a lot of saving in this process. But I must also indicate that this is not the only way that we are going to utilize in order to mitigate and address the issue of load shedding. We also, if you remember, during the State of the Province address, the Premier has indicated that the priority is being given to health, so that we look at other alternatives like your solar panels. We are also looking at inventors that, especially on our primary health care, the clinics, that we are going to use that. But people must understand that for a hospital, even if I have solar panels or inventors, you still need a diesel, because the power that you need, load shedding can be 12 o'clock midnight, and you might have the whole day, it was raining, or the whole week. So it means you will end up with a power failure. So the generators there, it's not a wasteful expenditure. Actually, even if EXCOM is fully functional, even if you have got solar panels, you would still need generators and diesels, because their capacity are able to pull through our equipment, especially if you look at our theater, our chiller plants, you look at our linear accelerators for oncology patients. So those equipment will never be able to pull through by the where you do not have a adequate power supply.
And it's important, and thank you for that, Doc, for raising the issue around other alternative sources of energy, and that you are looking into that as a department. Tell us a little bit about the capacity of the generators. So the lights will remain on when there are blackouts at these health facilities. Are they operating at 100% capacity, or are they prioritizing certain departments within there? You've mentioned oncology as an example. How exactly is the power distributed through the generators? Is the entire facility working, or is it distributed to important departments within a hospital or a clinic?
As we have indicated, that currently the generators that we have within the hospitals and department, they range from 350 kVAs, you've got 500, you've got 450, you've got 800. The 800 is the largest. So a hospital will depend on the number of beds. Hospital, which is like Pietersburg and Mankweng, which are the biggest facilities in the province, these are our 2 tertiary. They are operating in between 3 to 4 800 kVAs, and they also have got another 2 500 kVAs. So that it's to make sure that all the areas are covered. 800 kVA on its own, it will not be able to cover the whole of Pietersburg Hospital. So it will depend. Level 1 hospital, you are looking at Butlokwa Hospital and look at the number of beds that are there. They don't necessarily have an ICU, but they do have a theater, they do have laundry, they do have kitchen equipment, which require also a maximum power for them to be able to function. So you then look at the size of the hospital and decide whether you will allocate a 500 kVA or an 800 kVA. But what is currently happening is that we don't even want a single place in our department, in our hospital. The priority starts with the hospital itself, where all the wards, the theaters, the ICU, the casualty, all of them are fully functional. Of course, areas like your theater and your ICU, which has got these equipments, like your oncology unit, where you've got this equipment, you then allocate them to a bigger generator like your 800 kVA. But areas like your orthopedic wards, where the most important thing that is needed there is lights, even at night, you can do with connecting them a 500 or a 350 kVA. So this is how we operate. It will therefore depend to say, you're dealing with a theater, you need chiller plants here. This is what they require, high voltage. So that is how it's happening. So there's no area within the hospital that must find themselves in the dark, whether it's lights, whether it's equipment that needs to function. Hence, we are saying when we bring in also the investors and the power and the solar panels, they will then also be able to assist in especially in the areas like your clinic area, where the most important thing is your lights. Because in terms of the equipment that they use at our clinic, whether it's to check your blood pressure for the patient, we usually connect them with batteries that are, we refer to them as UPS, the uninterrupted power supply, meaning those equipment, when power fails, their own batteries will be able to keep them for 2 to 3 hours.
Finally, Phophi, I just want to shift our direction of the conversation to tuberculosis. We were observing World TB Day yesterday. It has previously been an issue in the province of Limpopo, and I just want to know, as the MEC, while we have you, the plans that are in place, not only to educate people on tuberculosis and the stigma associated to it, but the treatment that is available in the province for those who find themselves diagnosed with tuberculosis, whether it be in its original form or the drug-resistant form.
If you remember when we had issues with TB in the province, and I think eNCA was one of those that covered the story in a negative way, while it was a plan which today had yielded positive results. It's when we try to start to decentralize the treatment and management of TB, including the multi-drug resistant, to say there are certain patients who can stay in the Mudimule MDR, but other patients can go and be managed in all our hospitals, where we then started to build or renovate old wards and make them TB wards, because we wanted to reduce the default rate. Today, we can with pride indicate to you that the defaulter rate, if you look at the last financial year, it was at 10.5% of defaulting patients. Today, we are at 6.4% for this financial year. We want to strive towards zero. If you look at the number of new cases of TB, you go to as late as 2019, if you look early 2019, and then you look at where we are today. While we were disturbed a bit by COVID-19 because the focus was on COVID, at that time, 2019-2020 financial year, we were at 11,800 plus cases of TB. This past financial year, we are only at 7,800 plus in new TB infection. If you look at the cases of MDR, we were at 309. Today, we are at 255, the 17% reduction. So you look at all those plans that we came up with, because unfortunately, as a province, whenever we bring a new thing and a change, it always gets backlash. but people do not like to go back after some time to want to understand why was the MEC and their team so insisting on this particular plan. We know we do research first, we study and want to understand, will this yield results? Every decision that we take in this department, in this province, is to make sure that the patients benefit a lot. We will never do any decision which will jeopardize the lives of our ordinary people. So in terms of our battle of TB, we're still worried about the stigma that is attached to TB, and we are also echoing the calls by our Deputy President yesterday when he launched our National Strategic Plan by the theme to say, yes, you and I can end TB today. We're saying, starting with me and you, Ramathuba, do you know your status? Do I know mine? Have I been screened for TB? Once I get screened, I'll be able to be put on test if I do meet the criteria. If I test positive and I'll be given treatment immediately. In terms of the new patients that we are putting on treatment, we are at 97% today, which is a positive moving from the previous 88%. Now, when you are on treatment, are you going to complete it for 6 months? Will you not stop? Because TB treatment, after you take it for 3 weeks, you feel better, the symptoms are gone, you think you're cured. So you and I can make sure that all our family members are screened for TB, our neighbors, our colleague at work, and we complete treatment. TB, it's also highly infectious, but TB can be prevented and TB can be cured. So yes, it's still #1 cause of mortality rate, including in our province, and it's even surpassing HIV and AIDS. So let's take this matter very serious, and a call for us to say, we don't only work alone, we work with traditional healers, we work with a faith-based organization, we work with the traditional leaders and all community leaders, civil societies there. The 2 days, 23rd and 24th, we spend them having dialogues around Ramathuba to deal with the matters of TB. Finally, what I appreciated, what I learned that day, was our traditional healers who says, when you are diagnosed by TB, of TB from a clinic, do not come to us and start to say, I've been bewitched, because their bones, even if they throw them, they will never be able to diagnose TB. The bones can be able to see other things. Their ancestors can show them other things. They will never be able to show them TB.
Well, Phophi, thank you very much for your time this morning and for clarity around the TB plan that you initiated in the province. That is Dr. Phophi Ramathuba speaking about how the department, her and the team are dealing with load shedding, but also an update on tuberculosis in the province and the plans in place to deal with it and get people effective treatment.